Well, thanks very much. And okay, this is going to be my last talk, so you're almost done with me. So it's I want to at least keep droning on with that. So it's and the disclosures haven't changed since last time. So let's. So I was sort of thinking, how should I do this? And I figured it might be good just to go through the basics of PRRT and what's happening, what is the current PRRT we have, and where we might be going, and then hopefully we can take a lot of questions because those are always really helpful. So what does PRRT stand for? So let's talk about the terminology. So the P is peptide. So peptide is a short chain of what's called amino acids, essentially the building blocks for proteins. So that's the P. R stands for receptor. So that's a molecule that binds to a specific signaling molecule that's called a ligand and initiates a response to the cells. I'll show you pictures too. And so there's another R. What is that? It stands for radionuclide. So radionuclide, technically the definition is an unstable form of a chemical element that releases radiation as it breaks down. So something that radiates. And T, therapy, well, no need to explain that. And so that's PRRT. So, and let's talk about our friend here, the somatostatin receptor, because this is, we're going to keep coming back to this concept. So in the middle here, we have a neuroendocrine tumor cell, and you can see, so this is the nucleus, all of these like little things poking out of the surface, like little flaques on the surface. These are the somatostatin receptors, and typically what would happen normally is that in a normal cell that has the same receptors, there would be a hormone or something that binds to this receptor, and then the receptor sends a signal into the cell telling it to do stuff. And that's called cell signaling, and that's how the cells talk to each other, and how we can make a lot of the cells in our body do the things they should be doing. So, and well, now that this receptor is there almost all the time in the well-differentiated neuron tumors, can we use this as a target to deliver a radioactive chemical, so like a radioactive sticky bomb? And we can. This is the same signal we use for the octreotide and lanreotide. So it's been there. We can see it. So why don't we target it? So let's talk about how we find out if the somatostatin receptor is there. So here we have the neuron tumor cell. See those little blue things on the surface here? So these are the somatostatin receptors. And we can take a picture of the net cells if the receptors are there using PET imaging, and I'll show you how that works. So first you need the receptor. It's just like zooming out one of those little blue things, and then you need something that sticks to the receptor, like two pieces of Velcro or two magnets, and that's the somatostatin analog, the peptide. Then you need something, a glue or something that something sticky, and you need something that glows in the dark. So you need these three things. So you need the something that glows in the dark we can take a picture of. You need something that recognizes the receptor. You need something that glues it all together. And then we can give it IV, and we let this sort of float around, and it floats around everywhere in the body, sticks to the tumor cells like two pieces of Velcro, and we can, like this, or sticks to the tumor. And then we can take a picture of it. And so this has many different names. You hear like gallium-68 or copper-64, PET scans, dotatate PET, DetectNet, NetSpot. These are all different names of the same thing. But all of them are somatostatin receptor imaging or PET imaging. So SSTR, or somatostatin receptor, that's what SSTR stands for. So I would just say use that name, and this is the picture I showed you before. It's just best to call this what it is, what it does, instead of using some brand names or something for it. Just call it SSTR PET. It's a somatostatin receptor PET scan. Some people use gallium, some people use dotatate, like copper. Dotatate is actually a misnomer, so that's not what we're doing or imaging. So I'm trying to move away from that, but I keep saying dotatate PET. So it's a work in progress. So you saw these pictures before. Again, we can see those how these tumors light up here. Exactly what I showed you before. The liver tumors that may or may not show up on the venous phase imaging. Again, this is just to revisit that small pancreatic neuron tumor that really looks much bigger on the PET scan. So you've seen these before and these as well. But what I wanted to point out here, and this is actually an important thing, is that if we look, for example, at the brain, and we think about the other PET scan we have, which is called a metabolic PET scan, or FDG PET, the brain is always on, or I sure hope it's always on. And so the brain runs on sugar, and then when you give someone radioactive sugar and you take a PET scan of them, on such a PET scan, the brain always lights up really bright because it's running on sugar. Same with the heart. The heart would look bright. With the SSTR PETs, this is not a metabolic PET. We're really trying to locate the cells within the body. We're not looking at metabolism. So here you can see there's no activity in the surrounding brain, but only activity in the tumor. Same with the heart. So there's no activity in the heart, only the tumor. So if this was the other PET, what's called the FDG or the metabolic PET, we wouldn't be able to see this tumor. So because everything would light up so bright. So that's the difference between SSTR PET and metabolic PET. And then there's a third PET, just to make things complicated. If someone has a prostate cancer, we use a totally different PET for that. So I had one patient not too long ago who had a neuron tumor, a lymphoma, and prostate cancer. He needs 3 different PET scans. So that's hard to get explained to insurance carriers. So, but it's possible. I found out it's possible to explain it to them. So how does this work in practice? So let's just, or PRRT. So now we're into PRRT. We talked about the imaging. So how does PRRT work? So again, we will revisit the net cell that has these receptors on the surface of it. So, and I'm going to show you the components of PRRT. And now I'm actually moving away from PRRT and talking about RLT, which I don't have there, which is radioligand therapy, which is the same as PRRT. But not all radioactive therapy uses the peptide. But that's a topic for a different talk. But for the time being, PRRT is a perfectly appropriate term. So again, we need to have the target. Here's the target, the somatostatin receptor. We need to have something that sticks to the target. And we need to have now something that kills tumors, not just something that glows in the dark. We need to have a radioactive chemical that can actually kill tumors. And that would be, in this case, lutetium-177. And again, we need the glue to keep it all together. And then we give this IV. It floats around, sticks to the tumor cells wherever they are, delivers the radiation to the cell, and kills it that way. So right now, we only have one approved, which is lutetium-177, also known as Lutathera. There are other lutetium compounds working their way through clinical trials. Something called lutetium dotatok is on its way. And then we have the yttrium, which we used to use back in the day, but we don't anymore. And then we have the alpha particle PRRT, which is on the horizon. I'll show you a little bit of that data. And that, for now, is only 2 of them, actinium-225 and lead-212. So we have a lot of activity there. So PRRT, just to remind you, there's a peptide, there's a receptor, there's a radionuclide, and we have PRRT. So that's how we got the name. And so this is essentially just lethal radiation delivered right to your doorstep. So you send this IV, it latches onto the tumor cells, sends radiation to the tumors, and kills them that way. So this is how it works. And this can stick to other normal cells in your body, but those would be like the pituitary gland and the spleen. But those cells are not actively growing, and they seem to mostly just brush it off. And so it's not like we kill the pituitary glands or the adrenal glands with this. They're amazingly resistant to radiation, but the tumor cells are not. So this is the current FDA approval, so really only for lutetium-177 dotatate or Lutathera. So you have to have the receptor present there, and it can be either foregut, midgut, or hindgut. That's like the pancreas all the way down to the rectum. It's not yet approved, to my knowledge, for lung neuron tumors, but we use it for that, and they have to be well differentiated. So we just got that question here a little bit ago with neuroendocrine carcinomas. Why do we not use PRRT there? And the short answer is that we just don't have the data, and it doesn't seem to work. So it has to be well differentiated. So I wanted to pause here and take you through one slide of statistics. So because when we look at the the data I'm going to show you, I'm going to be talking a lot about like survival, and survival can mean a lot of different things. So it can be something called overall survival, which is life expectancy, something called progression-free survival, which is the time until a tumor that was previously stable starts growing, and there's a lot of things like that. So let me see if I can walk you through this. So let's say we have like 24 patients here, so who all start at one time point. Let's say they all have growing neuron tumors, and we are going to be giving them a PRRT. And then at some point, they will start having growing tumors again, because it doesn't last forever. So when half of them have had tumor growth, so let's say now only at this time point here, half of them still have stable disease, but the other half have actually had tumor progression. So you can see that this is what's called a survival curve. At the beginning, no one is progressing. At this time point, half of them have had tumor progression. So if we look at that time point, that is what we call the median survival. So this is the time where half of your patients have had what we call the event of interest, which could in this case be tumor growth, could be death, could be time until the tumor comes back after surgery. And this is a number you're going to see a lot of. And that can be like life expectancy or time to tumor progression or recurrence after surgery. So if you think about it, you had 24 patients who all had the pancreatic surgery for localized tumor, and then at a certain time point, half of them will still be tumor-free, the other half will have had recurrence. Well, that would be the median time to recurrence. So, and the reason I'm showing you this is that these are the metrics we use when we assess the outcomes of clinical trials. So let's talk about some clinical trials. So, but let's first talk about where PRRT might fit in. So studies looking at sequencing, what cards to play at what times, unfortunately are mostly missing. We don't have those data. So with all of the available options, we really don't know where the PRRT fits into the puzzle. So we're getting more data, but sometimes you have just a few different options and you don't really know if PRRT is right here or if it should wait or use it later. So you just don't have those data for a lot of our patients. But let's look at the data we have. So this is NETTER-1. So this was the first PRRT study, the one that got Lutathera actually approved. So 230 patients almost with small bowel neuron tumors all had tumor growth on somatostatin analogs, and they were all positive on SSTR imaging, which back then was actually mostly octreoscans scans. They got randomized, so the computer decided half of them get double dose sandostatin or octreotide, half of them get lutetium-177 dotatate or PRRT. And the primary endpoint was progression-free survival, median progression-free survival. And this later, so it didn't have a crossover, but 36% of the patients ultimately, those who got octreotide, got PRRT later through different mechanisms. So we have to keep that in mind. And then these are the progression-free survival curves, and I'm going to show you how this actually works. So you can see, well, we can all see that the green is really different from the black, so you can sort of drive a car through this, it's so white. And and the progression-free survival is not reached in the control group. It has been reached since. It actually ended up being about 28 months. But here's how this works. So if we look at the progression-free survival at 12 months, so let's just take a look at the 12-month mark here. If you got PRRT, 85% of the patients did not have progression at the 12 months after completing therapy. If you look at those who got octreotide, 30% of them did not have progression. So you can see 70% of these guys had tumor progression at 1 year. Only 15% of these guys. So this is the difference in the progression-free survival. So these are the numbers we look at. We can look at what's called median, but sometimes it's just easier to look at a certain time point, like 1 or 2 or 3 years, and I'll show you some more examples of that. But interestingly, in this study, the overall survival was not statistically different, meaning that the patients who got PRRT, they lived longer numerically, but wasn't statistically significant. So the question is still there, well, how much does PRRT extend a person's life expectancy? And I think it will. In my mind, there's no question it will be. We just don't have all those data yet. It takes, because these tumors are slow growing, it takes a long time to get all this information. Okay, let's look at another two. So these are patients who have never had any therapy, and they had all of them had higher grade tumors, grade 2 with KS7 more than 10%, or grade 3 well differentiated with KS7 up to 55%. Here they were randomized, and here the randomization is a little different. So 2 out of every 3 got selected for this arm with lutetium up front. They had never seen any therapy. And then 1/3 got octreotide at high dose, just like they did in the other study. And then there was this option for what's called a crossover. So if you ended up on this arm and then the tumors grew, then you had the option of crossing over to or getting the radioactive therapy, and about half of them did that. Again, the primary endpoint was progression-free survival, and this is what the survival curves look like. And if you look at the primary the endpoint, the progression-free survival, so those who got PRRT on average got about 23 months versus 8.5 months. So there's clearly PRRT is much better than in terms of delaying tumor growth. What we don't know from this study is overall survival, is life expectancy. We just don't have those data yet. But let's take a look at those time points. Now I'm going to just shake things up a little bit. Look at how did they do at 24 months, at 2 years? So let's look at the progression-free survival at 24 months. Well, 50% of those who got Lutathera or lutetium had not had tumor growth at 2 years from completing the treatment. This actually is pretty impressive. If we look at those who got octreotide, well, it's not ineffective, but it's just not as effective. So 20% of them did not have progression at 24 months, and 5% of them had a complete response to lutetium dotatate, which is something we had never really seen much before, which was amazing with this trial. And that probably is because these tumors are a little bit more faster growing and they're more sensitive to radiation. So moving on, this is hot off the press. So this is from the ENETS, the European Neuroendocrine Society meeting. This is a trial called COMPETE, looking at lutetium-177 DOTATOC. It's a little different. And in this study, patients were mostly previously treated with injections, either octreotide or lanreotide, were randomized to either receive lutetium DOTATOC for 4 cycles versus everolimus or Afinitor. Again, the progression-free survival was the primary endpoint. These are the curves, and you can see it's not quite as dramatic as is with the other studies, which could be different patient population, could be that everolimus was just better than the injections, or we don't know. We have never compared DOTATOC to dotatate or Lutathera with this compound, but you can see that there is definitely a notable difference, almost doubling in the progression-free survival. But here they actually have early survival numbers, and this would suggest that the patients who got, that's the blue line, who got the octreotide or got the lutetium, they seem to live a little bit longer. But a lot of the patients ultimately got PRRT, so it's hard to say how much this really truly improves the outcomes. But if we look back at life expectancy of patients with advanced neuroendocrine tumors in the US, we're seeing people living longer than ever. So it's hard to not believe that the radioligand therapy has something to do with it. And this was well tolerated. I won't show you that. This actually is a really, really interesting study. So this is what's called a retrospective study. This was not a trial. So these are the Italians looking at 500 patients from 25 centers, and they looked at patients who all had growing tumors on injections, and they looked at those who started with what they called targeted therapy, which could be everolimus or Afinitor or sunitinib or chemotherapy even. And then they looked to see, is there a difference in what's called the progression-free survival, whether you started with chemotherapy or targeted therapy, or if you did PRRT at the time of progression on injections. And they saw, yes, there's a big difference in progression-free survival, so 2.2 years versus 0.6 years. But then what they did was really smart. They actually looked at the life expectancy of these patients. Say, if you started with chemotherapy or targeted therapy, but then later you got PRRT, does it really matter? And it doesn't seem to matter a whole lot. So life expectancy, keep in mind these are patients with metastatic neuroendocrine tumors who have growing tumors on injections, life expectancy of 11 to 12 years. That's actually really, really impressive. But there doesn't seem to be much of a difference. So does sequencing really matter? Does it, as long as you get all of the active drugs, does it really matter if you get this card first or that card? So these are the questions we still need to answer. So based on this, it might not matter that much. What about PRRT to control symptoms? So yes, for refractory carcinoid syndrome with diarrhea and flushing, PRRT can be very effective. For patients with functioning pancreatic neuron tumors like insulinoma and some of the rarer tumors like VPOMAs and others, incredibly effective. We just reported our experience with PRRT in metastatic insulinoma. We actually looked at 60 patients with metastatic insulinoma at Mayo. It just came out 2 weeks ago. And PRRT is incredibly effective at controlling symptoms. And at the same time, there were 2 additional studies from Europe that showed exactly the same. So for metastatic insulinoma, for some of those functional pancreatic hormone secreting tumors, PRRT can be incredibly effective. But so can, for some of them, somatostatin analogs. And sometimes you have to use both the injections and the PRRT and even some other helping drugs with that. But the message here is PRRT really can control symptoms. What about PRRT before surgery to make tumors smaller so we can maybe ultimately get them out? So this is still pretty early on. This is actually a paper from India. This patient had a pretty large pancreatic tumor. We can see here, lights up really bright on the PET imaging, and then got PRRT for 4 treatments. You can see the tumors is really shrunk in size and much less positive on the PET. So theoretically, we could actually treat patients with really large tumors with PRRT, get the tumors smaller, and then surgically remove them. And we have Dr. Bolicio is coming up here as the next speaker to talk about surgery for this. And not sure if she's going to talk much about perioperative therapy with chemotherapy or radioactive therapy before, but it can be done. This study here at the bottom, 34 patients from Italy, and treated with 4 cycles of PRRT. Each bar is a patient, and if the bar goes, and this is the baseline, if the bar goes downwards, it means that the tumors got smaller. If the bar goes upwards, it means the tumors got bigger after PRRT. And you can see only 3 of the 34 had tumor progression. Everyone else either had stable disease or regression. And those orange bars here just means that they had more than 30% reduction in the size. So you can see, even in patients with localized tumors, PRRT is really good at making them smaller. The question is, does it matter if we can take them out anyway? Do we necessarily need to make them smaller? But we're starting to use this a little bit before surgery for the really bulky tumors. Use either CAPTEM chemotherapy or PRRT just to make them a little smaller, so it's easier for the surgeon to get them out. Well, there's always a dark side to things, including PRRT. So overall, really, really safe. It can drop your blood counts, as some of you have experienced if you have had PRRT. And then there is the dreaded 2 to 3% risk of leukemia, which can be higher if you have had chemotherapy before PRRT or if you have chemotherapy after PRRT, maybe as high as 5, 6, 7, 8% then. And it happens typically 12 to 18 months, or typically 3 to 4 years after PRRT, but can happen as early as 12 months later. And it's an incredibly hard leukemia to treat. It's almost always fatal within a couple of years. And so just be aware of that, but then think of that. If 2 to 3% will get leukemia, that means that 97 to 98% will not get leukemia. So this is a low risk, especially if you're faced with growing tumors, you have effective therapy. You don't want to withhold the effective therapy because of a low risk of leukemia. Well, for patients with a lot of metastases to the peritoneum, the lining of the intestines, you can sometimes see bowel obstruction. We can see transient pain, especially in like bone pain. And we're seeing a little bit more hair loss with the alpha particle therapy. Not so common with beta radiation like lutetium. So what's new in PRRT? So we have what are called PRRT plus. So this is PRRT plus something else like chemotherapy, immunotherapy, targeted therapy. All of these are being actively tested in clinical trials. I've seen trials reported for all 3. But these are tiny trials, 20, 30 patients, some showing really interesting signals of activity. We just need more data before we can use these combinations routinely. What about high-grade neuron tumors? Yes, for the well-differentiated, the NETTER-2 study showed clearly a benefit. This study has completed, called COMPOSE, using lutetium dotatate. So we should get those results in the next few, possibly later this year. And then we have some other newer drugs here and better ways to predict the toxicity and efficacy, but all of them are still pretty early on. So, finally, alpha particle therapy. Where are we going with that? So alpha particles are essentially helium nuclei, so 2 protons and 2 neutrons. I actually had to go back to my college physics to look this up. And there are several different types of them. They have a much higher energy but they travel much shorter. So if they hit a tumor cell, they totally like pulverize it, but they don't really travel that far. So when we can attach these to someone's analog and we can deliver them to the tumor cells just like we do with lutetium, but these studies are all like really early on. So this is something that I sometimes show. If you think of your house as tumor DNA, and this is the beta damage to your house, it's a golf ball coming in through your window with lutetium-177, well, this is alpha particle therapy. So this is, that's a Mack truck. And so if it hits your house, it just totally shatters the DNA. And this is a little complicated maybe if you look at the alpha here. So it has very high what's called LET, which is linear energy transfer. Just whenever there is that the DNA, and if you go back to like biology, DNA is like this sort of twisted double-stranded helix. So the lutetium, the beta, breaks maybe one of the two strands, doesn't completely destroy it, but the alpha particles really cause a lot of what's called double-stranded DNA, and theoretically should be much more effective at killing tumor cells. But the thing is that we don't have good data yet. So I just wanted to show you that, or before I go into the key take-home points, is that we have trials looking at alpha particle therapy. We have the Action 1 trial looking at actinium-225 in patients who previously received lutetium. So this trial is quickly winding down. I think this trial is going to be done in the next 3 to 4 months. And so it's a global trial all over the world, and Mayo is putting, we have a lot of our patients are on it now. And we have a couple of other trials. We have a first-line, what's called a first-line PRRT trial with the LED212, which is a company from Iowa. That's also going well. So there are more alpha particle trials coming. But just to summarize all of this, PRRT in grade 2 and grade 3 nets, we saw that in the NETTER-2, really effective, high response rates, very reasonable first-line option. You have a well-differentiated grade 3 NET or a high grade 2. You can actually start with PRRT without going first on the octreotide or lanreotide. That is a reasonable choice. What about PRRT versus everolimus? We saw that in the COMPETE study. PRRT is more effective. That's actually lutetium dotatok, who was superior to everolimus, and there were no new safety signals, as well tolerated as the other PRRT. Does sequencing matter? Well, we don't really know. So the radioligand therapy seems to be superior to all of the other arms, but at the end of the day, will it change life expectancy? Time only will tell when we look back at these trials 5-10 years down the road. And then alpha particle therapy is here, probably here to stay, effective in patients with both PRRT naive and patients who've previously received PRRT, and ongoing trials. So really, if you can go on one of those trials, consider it. The only way we can move this field forward is for patients like you to enroll on clinical trials. Otherwise, we're just stuck sort of spinning our wheels, and we don't really know where to go next. So thankfully, the neuroendocrine tumor community has been very sort of embracing of clinical trials, especially radioligand trials. And that's it for therapy. And then we'll take all the questions. That's a volcano from Iceland.